we're standing between you and lunch, so we'll try to be on time and efficient. But just wanted to acknowledge our wonderful working group for the post-TB lung disease management and prevention plenary, and their names are listed here. And a special shout out to our early career delegates, Guy Mula from Zambia, who unfortunately couldn't be here with us, but worked really hard on a lot of the stuff that we've put together, and Seke Muzazu, who you're going to hear from in just a moment. So it's my absolute pleasure to introduce everyone. Briefly, we'll have 3 talks as part of our plenary session today. So first, you'll hear from Seke, who's a medical doctor, clinical trials specialist, and currently a PhD fellow at the Center for Infectious Disease Research in Zambia. And then Seke and Guy work together on this talk about PTLD interventions and reviewing current evidence for management and prevention of PTLD. Then you'll hear from Bob Wallace, Chief Scientific Officer at the Orem Institute, and his talk focuses on clinical updates and clinical trials for HDT, and it's a recorded talk, so hopefully that'll go okay. And then last but not least, you'll hear from Dr. Anthony Byrne, pulmonologist and researcher at St. Vincent's in Australia, and in Partners in Health in Peru, and he'll talk a little bit more about treatable traits. And so without further ado, let me welcome Seke.
Afternoon, everyone. As introduced, my name is Seke Muzazu. If Zazu sounds familiar, it's probably because of the very wise bird from the Lion King. Yeah. So I will be presenting the review of reviews on PTLD interventions, and my team is projected on the screen. And I would probably have heard enough about the epidemiology of PTLD, and I would probably not go into details of that. But I did want to highlight that despite the growing recognition, and this conference is one of the reasons for that, there still remains a lot of research gaps and gaps in the guidelines as well, as the previous teams had also alluded to. So in our review of reviews, we project here just a few of the studies that we used and referred to, and we wanted to particularly highlight the 2 top ones, which is the scoping review by Banje et al. And also Eileen. Both were published in 2024, and there are 2 ongoing reviews by I think Dr. Ghana, who's here, and also Dr. Maria. These are coming up, and please look out for them. So getting into our presentation. So in our review, we're able to establish that PTLD interventions really can be categorized in 2 phases, and this is based on timing. And the timing is the time point for tuberculosis cure establishment. So the duration when the patient is receiving care or has active TB infection, that's when you can implement your prevention strategies, and then after cure, you can implement your management strategies, and we'll look into depth of that. So on this slide, what you see is sort of similar to what we saw on the previous slide, but here we wanted to highlight the focus as the goals of therapy, and the goals of therapy in the prevention or during TB treatment stage is really to prevent further pathology. As mentioned again and again during our sessions here, is by the time the patient presents to you, you are probably going to be playing catch up, because they already have had TB, and if they have symptoms, they already may have some existing lung pathology. So we want to prevent further pathology from ensuing. And in the management stage, the goal of therapy there is to prevent impairment and disability, to improve chronic respiratory care and provide therapies as you see them there. We also wanted to highlight on this slide that someone who develops post-TB lung disease is still at risk of recurrence, and they might still get TB. As we heard from some of the stories shared this morning, you can get TB several times, and it's quite disturbing. So we want clinicians to be aware of that and to be looking out for it, even as you are treating them for PTLD. So for the prevention of PTLD, starting right at the bottom left, optimization of TB diagnosis and treatment. At the point when you see your patients, like I said, we're playing catch up, so you don't have any more time to waste. If you can get them started on treatment, the sooner the better. The more you delay from the point they present to you and getting them into a getting a correct diagnosis, for example, and getting them onto the right therapy, the lung pathology is getting worse. Next is a lifestyle adjustment, and I like that the cardiovascular team also talked about this, and this is smoking cessation. We cannot overemphasize the need for tobacco and its impact, and how smoking cessation can also be useful in PTLD prevention. So it's one very important strategy. The next one is host-directed therapies. I will not go into depth of this because we have a session coming up, but these are essentially adjunct therapies that can be used, or chemotherapy, some of which can be your steroids, and these will be given alongside TB treatments to ensure that the patient has the best potential experience during their care. Nutritional supplementation categorized as broad caloric intake or targeted intake, and when we say targeted, you can find literature on this. The reviews that we looked at highlighted a few of them in terms of your calcium, your vitamin D, and a few others. And finally, the psychological support. Again, this can be both provided at the health facility, and in the setting where I come from, usually we have to depend on the relatives and the families, so bring them into care as well. Moving on to the management strategy. So on this slide, I sort of just tried, there was a lot of information in the reviews that we found, and we tried to summarize it into a slide or two. So it's really the pulmonary rehabilitation, use of antimicrobials, surgery and bronchoscopy, nutritional support in health therapies, and complementary therapies. You notice that pulmonary rehabilitation is useful in both as a prevention strategy and also as a management strategy. And on the right of your screen, you will see that we show there's enough evidence in literature that indicates that pulmonary rehabilitation does improve lung function. It improves health-related quality of life and also respiratory disability. It is, of course, has its own pitfalls, and we will discuss these on my next slide. The other, I will also not go into the detail looking at my timer, but of all the others, but as you can note is that generally the evidence is there on how they can even reduce exacerbations, reduce hospitalizations. And one element that came up again in yesterday's discussion was around oxygen therapy, and it does come up as part of the complementary therapies that exist, but thinking about how pragmatically this can be implemented in our low-income settings is another headache for another possible conference on this. But this is like a summary of the management strategies for PTLD. We wanted to highlight specifically the evidence on pulmonary rehabilitation. So the bulk of the evidence we found in our reviews was on PR. And this paper by Elena Tell summarizes it nicely. They did a subgroup analysis that looked at the impact of pulmonary rehabilitation among patients both during and after care. And generally what we could see is that, yes, it has benefit in both during and after care, but the during treatment period becomes really critical to implement it. So let's not wait until the patient has been cured or has completed their TB treatment. If you can implement it from the day of diagnosis, let's get it started there. And these are some of the pitfalls I talked about. Accessibility, of course, cost, stigma, human resource and training and infrastructure. I liked how the team from Tanzania and Malawi actually implemented this using community healthcare workers, because then it makes it a pragmatic approach and a lower hanging fruit to overcome some of these barriers and challenges we highlighted in our review. Then the weight of evidence. On this slide, we simply wanted to summarize for you in our review of reviews where the weight of evidence in terms of research was sitting. And we also added a column to just discuss, to compare the evidence in the other lung diseases for the individual interventions that we had. And again, pulmonary rehabilitation had the most research going on, both observational and experimental, but there was also a lot of evidence of its utility in other lung health conditions. You have your COPD, your interstitial lung disease, and even in long COVID patients. Interestingly, there wasn't enough evidence for PTLD for things such as vaccination that we could find in the literature we looked at. Also the use of macrolides, but this was quite extensively published around bronchiectasis and a few others as well. However, the inhaled therapies, nutritional supplementation, surgical interventions, and psychological support evidence is quite clear. So that's sort of the end of the review of reviews. But we thought we should highlight some of the research gaps that came up as we did this search. So one of them was that there was a clear, overt heterogeneity in the study outcomes in the literature, which made some of the studies that had intentionally wanted to do a meta-analysis just end up and do a narrative review. So going back to yesterday's session about, coming up with research outcomes that are sort of uniform would be very helpful to close this gap. There's also limited strong evidence studies in the different interventions. As I showed, most of the work that's being done is on pulmonary rehabilitation, but there's still room for people in this room to explore and design stronger studies that can be implemented and build evidence in this space. There's limited data on the long-term outcomes. The number of studies we looked at, again, most of them followed up patients for up to 24 months. I think on the first day, it was mentioned there's someone doing a study here that's following patients up for 5 years, so looking forward to seeing the data from that study. And the gap in the pediatric PTLD management population can't be overemphasized. Limited cost effectiveness and feasibility analysis. I don't know if we have health economists in the room, but this is definitely a niche space for you to jump into, because WHO will always ask for how much is it going to cost. I know my government will ask that because of the many competing priorities. There's lack of outcomes matched to clinical interventions, and this is speaking specifically to treatable traits. In the literature we looked at, it was a little difficult for us to understand what interventions were being recommended for what phenotype of patient or how different patients present. Again, going back to the heterogeneity in how PTLD presents, not only in the same age group or the same patient, even in the same patient, really. So it really needs to be explored further in research. Other areas are unclear tailoring of treatment approaches and various phenotypes, which I think I've alluded to already. And there's finally the research gap that we identified was the lack of contextual validation of measurement tools, and these are some of the ones that were being used for health-related quality of life assessments. The challenges we could collate from the data we looked at. Most of these we've already probably talked about during this symposium. The resource disparities between the research areas that were being included in the studies that we looked at, integration and on real-world application. I think this is also something that's very clear that whenever we do studies, whether it's a clinical trial, when you bring it back to the pragmatic clinic in the real-world setting, might not always be applicable. So maybe we should think about doing a lot more pragmatic studies, following our very nicely designed RCTs. And there's lack of clear treatment pathways as well, care cascades not very well detailed in the literature, and also migration and loss to follow-up was not exactly captured, but I think we have discussed that as well in the previous epidemiology talk. Cost and feasibility again. So in conclusion, these were some of our suggestions for implementation in terms of PTLD interventions and management and research, is that studies should focus on optimizing TB treatment outcomes through novel regimens, and treatments should be prioritized. There should be a form of decentralization of care to lower level facilities. This, of course, depending on your health system and your structure. There is need to integrate AI to enhance diagnosis and decision making. And when I talk about AI, I think we heard about CAD, chest X-ray CAD and its utility. There should be a focus on interventions, on optimizing timing and tailoring them to individual patients, defining clear outcomes, both research and programmatic outcomes in our assessments, and finally consider developing a potential predictor score tool that can be used for PTLD. And our team was really passionate about this one because we're thinking about that nurse in a rural health facility who's seeing majority of the patients. If there was a tool that simplified how they do their assessment and actually come up with what interventions I should actually start for which patient, that would be key. Thank you.
That was fantastic. Thanks, Seike. All right, we're going to see how my internet skills are. Can you press play on this slide from the back? Well, maybe.
Hi, this is Bob Willis. I'm very sorry I'm not able to attend in person, but I'd like to spend the next 10 minutes or so talking about host-directed therapies and lung recovery post-tuberculosis. TB host-directed therapies are immunotherapeutics that alter intracellular, innate, or adaptive immune characteristics to either hasten eradication of MTB infection or ameliorate lung immunopathology. There are a surprising number of trials dating back a half century that have looked at this in one way or another, and I've given a list of several here. I will briefly go through this older literature and then talk in more detail about current research. Corticosteroids are probably the most widely studied drugs. You can see that these studies began within a year or two of the first steroid preparations becoming available for clinical use. I have tried to arrange them here in order of ascending dose. And I have constructed a heat map to look at various types of evaluations. So constitutional findings refers to things like fever, weight gain, sedimentation rate, and body as a whole symptoms. Chest radiography was done in most of these studies, as was looking at sputum cultures over time. Only a couple of them did measurements of lung function. And unfortunately, for the ones that did, they often were not the same techniques that are used today. But you can see, for the most part, the studies that gave sufficient doses saw some effect in each of these categories. They may not have reached the level of clinical significance, but they were of interest. I'm not aware, however, of any current trials of corticosteroids to look at post-TB lung disease. There also have been quite a few studies of vitamin D done more recently than those of corticosteroids. There is not a really good way to order these. You can look at cumulative dose. I have also factored in latitude because this tends to be closely associated with vitamin D deficiency. And these studies, for the most part, failed to show effects, either microbiologic or on the lung. These studies of other agents, I think, are where things start to get more interesting. And I will go through some of these in more detail. I think you may be familiar with some studies of metformin, of dovramolast, which previously was called CC11050, and some of these others. So I will touch on some of the more interesting of these agents in detail. So dovramolast, or CC11050, is a phosphodiesterase inhibitor, a type 4. And these agents reduce pro-inflammatory cytokine production by inhibiting cyclic AMP degradation. So cyclic AMP goes up and TNF goes down. In preclinical studies, CC11050 ameliorated lung pathology and reduced matrix metalloproteinase expression and collagen deposition and pathology in general. And that was the main reason for moving this ahead into clinical research. A small trial that we conducted in RIF-susceptible TB showed superior recovery of FEV1 that appeared to persist beyond the period of drug treatment. This was in the TB-HDT trial published now back in 2021. This was a relatively small trial. There were 40 subjects in each arm. And it was problematic because the metabolism of CC11050 by CYP3A4 required that we substitute rifabutin for rifampin. And this meant that fixed-dose combination tablets could not be used. It's hard to see how this drug would advance in clinical research in drug-susceptible TB, but the pathway is quite reasonable for rifampin-resistant TB. And we have a trial in that patient population that will report findings out next year. Statins are also of considerable interest in improving TB treatment. They accelerate the eradication of MTB infection in the mouse quite substantially. In some experiments, by 2 months or more. They act apparently by promoting phagosome-lysosome fusion and autophagy, in addition to reducing inflammation. There have been 2 published studies that I'm aware of, 2 clinical trials. One examined atorvastatin, that is the Lipitor, the most commonly used of these agents, at a dose of 40 milligrams, which is moderate. And that found improved culture conversion at 8 weeks and improved X-ray scores at 6 months. However, the other study of rosuvastatin at a 10 milligram dose found no effect on any of the parameters that they measured. So microbiology measured either at culture conversion or TTP change or MBL change, no effect on spirometry, no effect on imaging, which included a PET CT in a sub-study, and no effect on symptoms, that is the St. George's respiratory questionnaire. And the different findings in these 2 trials is puzzling. The 10 milligram dose of rosuvastatin is the smallest dose that's used clinically. These researchers selected rosuvastatin because it was minimally affected by rifampin. The 40 milligram dose of atorvastatin you would think would be reasonable. However, this undergoes substantial metabolism by CYP3A4, so that exposures may be reduced as much as 90%. So it's not really clear why one study would have shown results and the other not. There's also a great deal of interest in doxycycline as a matrix metalloproteinase inhibitor. These enzymes are key mediators of tissue destruction in TB. And doxycycline is a broad spectrum MMP inhibitor that is used clinically for the treatment of periodontitis. A small trial has been reported in RIF-susceptible TB that found doxycycline at a dose of 100 milligrams daily for 2 weeks, reduced multiple MMPs in sputum, suppressed type 1 collagen and elastin destruction, down-regulated type 1 and 2 interferon production, and various innate immune response genes, and reduced the volume of lung cavities, which is what the figure shows over on the right. There was no effect on sputum MTB burden. Doxycycline does have an MIC for MTB, but the required concentrations are rather high and unlikely to be achieved at this dose given orally. There is a larger trial that includes spirometry as an endpoint that is currently underway in Singapore. Several studies have and are looking at metformin. This is an AMPK activator and mTOR inhibitor that is used worldwide for the treatment of diabetes. Antimicrobial and anti-inflammatory effects are seen in multiple preclinical TB models. The one published study so far was the MET-RIF trial conducted in India that examined metformin at a dose of 1,000 milligrams daily in 300 some odd patients with RIF-susceptible TB. The study found superior resolution of cavities and lower levels of pro-inflammatory cytokines and chemokines in the metformin recipients, but various measures of culture conversion were delayed rather than accelerated as anticipated. And I've shown this over in the figure on the right as the proportion achieving stable culture conversion. You can see that the control arm is superior to the metformin arm, very close to statistical significance. The authors went on to do a PK sub-study in a smaller number of individuals in the trial, and this showed that metformin increased the clearance and decreased the overall exposures of 3 key TB drugs. The effect was rather small. It's not really clear if it would be large enough to have this effect, although it was statistically significant. It's also true, though, that this rather modest degree of delay of culture conversion is not really known whether it will have clinical impact. So there are 2 studies now that are following on to further examine this. One is the METHOD study that's led by Hardy Kornfeld. This is in HIV positive recipients, and the DRTB HDT study. It's one of the 2 experimental arms in that trial that we are doing. both studies will report out findings in 2026, and both will include spirometry. N-acetylcysteine, or NAC, is, I think, one of the most interesting drugs in this group. NAC provides cysteine that is required for glutathione synthesis. And glutathione, in turn, protects lung cells against death due to reactive oxygen species produced by innate immune cells, particularly MTB-infected innate immune cells. The reactive oxygen molecules are not very effective in killing MTB, but they can have lethal effects against mammalian cells. So glutathione is a mechanism to help prevent cell death. The process does convert reactive oxygen species to water, so that's helpful, but it leads to depletion of glutathione markedly in tuberculosis patients. This trial examined the effect of NAC 1,200 milligrams twice a day in patients with moderate or far advanced TB, 140 of them in total. You can see here the levels of reduced glutathione. This is the biologically active molecule. And there are, I guess, two important takeaway messages. One is that at baseline, the levels were only a small fraction of those found in healthy volunteers at the clinic site. And although with giving NAC, we were able to increase those levels, we did not get them anywhere near the normal range. And as you can see, it was given for 112 days. When we stopped administering NAC, the glutathione levels went back to the levels of control patients. There was no effect on sputum culture conversion, and there are now, but there was a large effect on the recovery of lung function. And I've shown here FEV1. The effect on FVC was similar. And it was of interest because it appeared to persist beyond the period of NAC administration. There are now two confirmatory trials to look at this. One of them is the NAC PTLD study, which just now is starting enrollment in 3 African countries, and the PAN-TB-HM trial, which includes sutezolid, and it has NAC in one of the experimental arms. The PAN-TB-HM study will report findings in 2026. I want to finish up talking briefly about MVAC, used as a therapeutic vaccine. I don't know how many people in this audience are familiar with this. This is a killed vaccine prepared from a non-pathogenic environmental rapid grower that has been studied on and off for at least 4 decades as an adjunct to TB therapy. So therapeutic vaccines are usually given to prevent illness. Here they're being used to promote recovery from illness. There were many trials conducted in the Gambia, Vietnam, Nigeria, Romania, Iran, and others that reported increased cure rates and decreased mortality. But these trials suffered from multiple methodological problems, including insufficient sample sizes, non-random treatment allocation, lack of appropriate controls, inadequate reporting, and high loss to follow-up. The most striking of these is actually what was called a phase 3 trial that was published just a few years ago. In this case, of an oral MVAC preparation rather than one that was injected. And this report failed to describe the inclusion and exclusion criteria or the study population, didn't show a consort diagram, listed no adverse effects, and inexplicably only included 1 month of study participation. Nonetheless, it was of interest because, like all the other studies, the smear negative proportions at 1 month were strikingly increased in the MVAC arm. So the reason why I'm familiar with this is that we conducted one study of MVAC. This was the Case Western Reserve University TB Research Unit. That was carefully done. We gave a single dose of MVAC or placebo to 180 HIV uninfected Ugandans. And like the other trials, found sputum culture conversion improved at 1 month. Interestingly, MVAC recipients had greater improvement on chest radiography at 6 months and at 12 months. And this has been seen in many, although not all, of the other studies that were done in other populations. There were 2 meta-analyses of these rather poorly conducted trials. Both found superior early culture conversion, and one found superior cavity closure and resolution of other X-ray lesions. But to my knowledge, none of these trials have looked at lung function. And I think this is probably a study waiting to be done. Because although the attention of most other researchers has drifted elsewhere, there is a Chinese biopharma company that has licensed MVAC and has listed on clinicaltrials.gov quite a large ongoing phase 3 trial of MVAC to prevent TB.
In the break, there will be the slides with the QR codes, which we love again on the database. And please enter your information. For the moment, we're going to make it accessible to the people who participated at the symposium. And with the help of Brian, it will be hosted at Stellenbosch University. So it will help a lot also for the next meetings to prepare, to make it interesting and keep us updated. And there will be some more information to follow on that. Thank you very much.
Thanks, Gunnar. Okay, so I think I've got like 5 minutes.
Hi, this is Bob Willis. I'm very sorry I'm not able to.
No, I don't have any time,
attend in
apparently.
person, but I'd like.
Okay, thank you. So, look, in this short amount of time, I just wanted to talk a little bit more about treatable traits. We've got some opportunity later today at 4:20